Okay, so once we have understood the spectrum of the clubfoot deformity, okay, and we have understood that there are two types, idiopathic and secondary. Secondary can either be neuropathic, syndromic, okay, and then you have the untreated or the late-presenting clubfoot, recurrent clubfoot, atypical clubfoot. There are the few terms that we have to know. Now, once you know the etiology and the cause of the clubfoot, the next thing is to look at the scoring. But before we begin with scoring, remember, as orthopedic surgeons, we should never be like horses with blindfolds, because sometimes we tend to do that. We look at only the limb, or only the hip, or only that she's got a tibia fracture, or that this child has a torticollis. But remember that you have to examine the child as a whole. Remember that as orthopedic surgeons, we are physicians first, and then we become orthopedic surgeons afterwards. Alright? So don't ever make the mistake of having a parent bringing a child with a clubfoot and you're looking only at the foot and forgetting about the child as a whole. I remember one of the exams where I was, in fact, one of the students, and my colleague was giving the exam, presented a clubfoot case exactly like this. And he said, diagnosis is idiopathic clubfoot. And the examiner said, are you sure? And he said, yes, I'm sure it's idiopathic clubfoot. And then, obviously, the child was all swaddled up because it's a small baby who was like 4 months or 5 months old. And then he took the swaddled clothes off, turned the child over, and there was a big pile of medical scene behind. Alright? So don't ever make this mistake of not examining the whole child when the child comes to you. So just as when you attend AO courses, we're talking about the personality of the fracture, but also understand that the fracture lies within an ecosystem. It's not just the fracture you're looking at. Because the personality of the fracture, the treatment of the fracture depends so much upon where the patient is coming from, whether it's a rural patient, whether it's a patient coming from a high-rise tower in Mumbai. What are the other comorbidities that the patient has? Is the patient diabetic, smoker, alcoholic? So all those factors have a role to play in the fracture healing and our decision-making process. So same way when it comes to clubfoot, please don't ever just look at the foot. The first thing we should do before looking at the foot, so in fact, whenever a parent comes to me with a child with clubfoot and they say, Doctor Sahab, dekho ye hai. I said, I don't want to look at that first. First, examine the child as a whole. Start from head to toe. Because what you tend to miss out, what you pick up immediately, a syndromic clubfoot, is not by looking at the foot, but by looking at the face. Because some of the syndromes are very typical faces. And we know that, for example, it's the Freeman-Sheldon syndrome. They have a typical whistling face syndrome, whistling face facies. There are some that I have shown you where there's hypertelorism, where the eyes are wide apart. There are some where you have low set ears, where you have very distinctive facial of trisomy 21. So always begin with the examination of the general aspect of the child first. So examine right from the facies to begin with looking at the various types of syndromes. Then don't ever forget to examine the neck, the back and the hips. So this is a standard thing. That's the very least as orthopedic surgeon you should be examining. Alright? I'm not asking you to examine the lungs and the heart and look for the stethoscope and all those sort of things. Let's leave those things out. But at least musculoskeletally, we should assess the child as a whole. So begin with the face, look at the neck for torticollis, look at the back, right from up to down, because there can be very overt signs of spinal dysgenesis, or there may be signs just like a hairy patch, a hemangioma, a double sinus, which we often tend to miss. Alright? So check the back. And then check the hips, because as Matthew has already showed you that there is some association between a clubfoot and a hip dislocation. So always check the hips, do the standard Barlow-Ortolani test for a young baby. For an older child, you can do the telescopy test. Walking age child, you'll see a limp, you can see a Trendelenburg sign. So only look at the foot after you have done the general examination. So follow the same AO principles that when you attend an AO basic or an AO advanced course, whenever you have a discussion and the cases come up, straight away they will say, don't just look at the fracture, please don't ask for the X-ray. First ask for the personality of that fracture. Ask for the assessment of the patient as a whole. And that's what we should do in clubfoot as well. So having done this basic assessment, the next thing, now we can look down at the foot. And now decide, okay, this is an idiopathic or this is a syndromic clubfoot or a neuropathic clubfoot. And then how I want to assess the foot further is what I want to talk about now. So with the presumption that we have done our basic general examination first. So in the foot, what we want to look at really is what is the severity of the clubfoot, because we already said that every clubfoot is different, and this looks like a very severe clubfoot, and there are some patients who come to you with a milder clubfoot. Okay, so we must be able to assess how much, because just saying clubfoot means nothing, because this child has a clubfoot and that child has a clubfoot and this child has a clubfoot, but every one of them has a different type of even idiopathic clubfoot in terms of severity.
And there are various scoring systems that have been used over the last 40 or 50 years. It's not because we know that Clubfoot is not a new entity, it's been there from time immemorial. So people have tried to quantify how much of deformity is present. And you have your various systems in place. Carroll came out with a system, you have the French method or the 𝐬𝐸𝐤𝐢 method of classification. And what is more commonly used today is what we're going to talk about, which is the Pirani method. Shafiq Pirani is an Indian born in Uganda and who then went to Canada to specialize as a Canadian orthopedic surgeon. And he devised this method which is very simple and easy to use. All right? And it's got basically just 6 points. And it's not difficult to remember. That's the reason why we use it in our program. If you look at our program sheets, you'll realize that all of them have the 6-point classification system of Pirani. Have all of you all heard of the Pirani system? Anyone not shaking their heads? Okay. So if you look at the Pirani system, it's not confusing, it's very easy to remember. I remember when I was doing my fellowship, one of my teachers told me that if you want to develop your own classification system, remember, never keep it more than 5 or 6 points because orthopedic surgeons can't remember more than that. If you want a system to become successful, never have a classification system more than 5 or 6 points. If you remember Salter Harris, the reason why it's become so successful as a classification system for physical injuries is because it has 5 types. Of course, there are additions to it now. But he didn't devise a new system, Salter and Harris. They took an old system which was existing and they just modified that and simplified it for us as orthopedic surgeons and said, okay, there's Salter Harris 1, 2, 3, 4, 5. So same way for Pirani, there are just 6 points and it's very easy. Okay? So I'll tell you how to do it. So out of the 6 points, there are 3 points for the midfoot and 3 points for the hind foot. Because remember that all clubfoot, even though they differ in terms of etiology and differ in terms of severity, they have one thing in common, which is the pathoanatomy. The pathoanatomy is that all club feet have the same pathoanatomy, which is 1, 2, 3, 4, CAVE. So all clubfoot have CAVE. And what is CAVE? C for cavus, A for adductus, V for varus, E for equinus. So every clubfoot has cave. And based on these 4 deformities, we are grading the club feet as what Pirani is doing. All right, so we're grading how much of cavus, how much of adductus, how much of equinus, how much of varus. And if you use the French system or the 𝐬𝐸𝐤𝐢 method, it takes into account the same cave deformity and breaks it up using a goniometer, saying in terms of degrees. Now, when you talk in terms of degrees, you need to have a goniometer to assess that. Whereas Pirani said it's too difficult to do all that in a busy clinic. It's good for research purposes. But if you're doing this in a busy clinic and you're going to sit with a goniometer for every child and measure 10 degrees of cavus, 25 degrees of adductus, 15 degrees of equinus, 30 degrees of varus, it's not going to be possible at all. Okay? So he devised a subjective system which is easy to use, using the same cave deformity, CAVE, and said that there are 2 deformities in the forefoot and 2 deformities in the hindfoot out of CAVE. Cavus and adductus are in the forefoot and midfoot, and varus and equinus are in the hindfoot. All right? So therefore, there are 2 parts to the score. There's a forefoot score and there's a hindfoot score. The forefoot score is assessing the cavus and the adductus. The hindfoot score is assessing the varus and the equinus. So then what are these values now? So in the forefoot, we are look, feel and move. It's like everything in medicine, isn't it? We inspect, we palpate, we auscultate. We've done that when you were a medical student. So same way here, we look, we feel and we move. So that's the same things here. So when we look, we are looking to see the medial crease in the midfoot. That indicates the severity of the adductus. Okay. So the medial crease, and it's graded from 0, 0.5 and 1, each of them. 0 means there is no medial crease, which there shouldn't be. If you look at your foot, there is no crease medially because there is no adductus deformity. So absence of something is a 0, which is good. Presence of something means there's a deformity. So 1 means that there is a severe deep crease, and anything in between is a 0.5. So if I say 0 medial crease, means there's no medial crease, which is what is normal. If we have a deep medial crease, then that's a 1. Anything in between is a 0.5. So that's look. Then the next part is feel. What are you feeling for? Any idea? In the midfoot? The tailor head? No, that is a moving sign. So in the feel sign, we are looking to see the curved lateral border. So what does the curved lateral border mean? Again, that's a sign of the adductus, another way of looking at adductus. So what happens is, if in a normal foot, you'll find that the whole foot obviously is straight. there's a straight lateral border. If you put a straight ruler or a pencil against the whole foot lies against it. Okay? In a clubfoot, because of the adductus deformity, if you put a ruler along the hind foot, the forefoot sits off, depending upon the severity of the adductus. If the whole forefoot sits off, that's a 1. Okay? If the whole forefoot sits along the ruler, that's a 0. And anything in between is a 0.5. So very easy to find 0 and 1. And anything in between is 0.5. So if only the toes are off, then that's a 0.5. If at the metatarso-phalangeal joint it is off, at the tarso-metatarsal joint it is off, that's a 1. And the whole foot is lying in touch with the hind foot, then that's a 0. So 0, 0.5, 1. Again a sign of adductus. So that's a feeling sign. And then we are moving. Now what happens in moving, and we talk about this in the next talk where we talk of the biomechanics of the foot and why the Ponseti method is so useful, because it works on the biomechanics of the foot. So here what we understand in a club foot is that the talus is the fulcrum and the whole foot is spinning around the head of the talus. It's a dislocation of the foot around the talar head. So what we're trying to do in the Ponseti method is we're trying to relocate the foot around the talar head. It's the opposite of what we do in the hip, but the principle is the same. When you talk about hip dislocation, the acetabulum is where it is and the head is dislocated. So we're trying to put the head back into the acetabulum. That's what we do by closed or open reduction. In a club foot, it's the same analogy where the head is where it is, but the acetabulum is dislocated over the head of the foot. So what we're trying to do here is we're trying to relocate the acetabulum pedis over the head of the talus. So that is what is called the lateral head of the talus sign. So normally if you look at your own foot, you cannot feel the head of the talus because it is covered by the navicular. Alright? In a club foot, because of the dislocation of the acetabulum pedis around the head of the talus, the talar head becomes prominent and the talar head is exposed on the dorsolateral part of the foot. And when it comes to practical session, we'll tell you how important that talar head is, because that is the fulcrum on which we are working. Alright? So once you see the talar head, you put your thumb over the talar head and you try to move the navicular into reduction over the talar head. If the talar head is fully exposed and you can feel it on the dorsolateral aspect, that's a 1. If the talar head is fully covered when you manipulate the foot, that's a 0. And if half the head is exposed, that's a 0.5. So that's very simple. So therefore, we have got in the midfoot, we have got look, feel, move. Alright? And all of them are signs of the forefoot adduction and the dislocation that is happening of the acetabulum pedis around the head of the talus. Now we come to the hind foot. In the hind foot, again the same. Look, feel, move. In looking, what are we looking for? Posterior crease. Okay? Now posterior crease in fact is the opposite of the medial crease. Medial crease should always be absent in a normal foot. In the posterior crease, there has to be multiple posterior creases, because that's how we have dorsiflexion and plantar flexion. Creases means movement. So if you have multiple small creases, that's normal and that's a 0. If you have a thick deep crease where you can't see into the bottom of the crease, that's a 1. And if you have anything in between, that's a 0.5. Alright, so that's simple. So just as we have medial crease, we have a posterior crease. And again 0, 0.5 and 1. That's a sign of, again, the hind foot equinus. The more the foot is in equinus, the deeper will be the crease. Okay? Then we have the next sign, which is of feeling. What are we feeling for? The heel. Okay? So normally if you feel your own heel, if you put your finger, there's skin and there's bone directly, because that's the calcaneum. In a club foot, as the equinus becomes more and more severe, the calcaneum goes more and more up, and the posterior tuberosity of the calcaneum can no longer be felt. We call it empty heel sign. Why is it empty? Because the heel has moved up into equinus. So therefore the heel feels empty. So therefore there's an empty heel sign. How do you feel the empty heel sign? You go at a 45-degree angle and you try and feel, is the bone below my finger or not? And Pirani says it's very easy to find out what is 0, what is 0.5 and 1, because it's subjective, but no doubt there's some way we should quantify it. So if it feels like your forehead, that means there's skin and there's bone directly below that, then that's a 0, which is normal. That's how you should feel the calcaneum. If it feels like your nose, where there's soft cartilage, but you press inside, you can feel your nasal bone, that's 0.5. And if it feels like your thenar eminence, where it's all soft, then that's a 1. Okay, so 0.5, 1. So that's the empty heel sign. And that's by feeling. And then we move to see the rigidity of the equinus. So normally we know that in the ankle you should have plantar flexion and dorsiflexion. So normally we should have at least 30 degrees of plantar flexion, at least 45 degrees of dorsiflexion. So if the foot is in severe equinus, obviously the foot is right down here. So if you can't bring the foot into a plantigrade position, that's a 1. If you can bring it to plantigrade, it's 0.5. If you can take the foot into full dorsiflexion, that's a 0. So it's very simple, really speaking. All right. So if you classify it this way, the Pirani score becomes very easy for all of us to understand. So there's a midfoot score and there's a hindfoot score. The midfoot score has look, feel, move. The hindfoot score has look, feel, move. In the forefoot and midfoot, what are we looking for? Medial crease. What are we feeling for? Curved lateral border. What are we moving for? Talar head coverage. In the hindfoot, look, feel, move. Looking for posterior crease, feeling for empty heel, moving for rigidity of equinus. So you've got 6 signs, all of them graded as 0, 0.5 and 1. So you have a midfoot score. The maximum score can be in the midfoot 3. In the forefoot or midfoot, the maximum score can be 3. So total score of 6. So if you have a foot which is scored 6 by 6, then you know that it's a severe club foot. Okay, and in that you can break it down further. So that 6 by 6, is it obviously it will be 3 in the hindfoot and 3 in the midfoot. But if you have a 5 by 6, for example, it can be that it could be 3 in the hindfoot and 2 in the midfoot. So that gives you an idea of which is the more predominant deformity. Is it more of a midfoot severity? Is it more of a hindfoot severity? So that's the advantage of the Pirani score. It gives you the total score, but also breaks it down into the midfoot and the hindfoot, so you can grade which is the most severe one out of the 4 different deformities. Okay, clear to everyone? Yeah. If you have any questions, feel free to ask. When you have the practical session, don't just start casting the foot. Begin by doing the Pirani score. Every time the child comes to us, we must do the Pirani score. So what's the advantage of the Pirani score? It's simple to use. It decreases over time. So what you'll typically see with the Pirani score, if you look at all the 3 components of it, the hindfoot score, the midfoot score and the total score, you'll see as you start casting the child, if you put it on a graph, the midfoot score drops rapidly because you're working on a long lever arm. The adductors and the cavus corrects very quickly, but the hindfoot does not catch up so much. So you'll find that if you put on a graph and plot it out, the midfoot score starts dropping very quickly from 3 to 2 to 1. The hindfoot follows much slowly. It's not that it doesn't happen. It does happen, but from 3, it might become 2.5, 2.5, 2.5, 2. It stays on a plateau for a long time. All right. And then the midfoot score comes down to 0 because we have corrected the midfoot part. And then the hindfoot is still tight, and then we do a tenotomy. And then once we do a tenotomy, straight away the hindfoot score also falls. So this is if you plot the Pirani score on a graph, you will find total score, hindfoot and the midfoot. The midfoot falls rapidly. The hindfoot and the total score plateau slowly. And once you've done a tenotomy, all scores come down to 0. So this is how you graphically also, it gives you an idea that there's improvement. And someone said that sometimes we are doing Ponseti plasters and we are giving 10 and 12 plasters. The number of plasters is not important because sometimes you have very severe club feet or you have older children or even adults where we're using the Ponseti method. It's fine sometimes to use 12 plasters. But if every plaster that you're applying, the Pirani score is remaining the same, all the counselors sitting here will highlight to you, sir, something is wrong. So they are no, because they can see the Pirani score. So you should be showing us every time you're doing the casting and manipulation that the Pirani score is changing. If you're giving 2 plasters, 3rd, 4th, 5th, 6th, and all those plaster Pirani scores remaining 4 by 6, 4 by 6, 4 by 6, 4 by 6, something is wrong with our manipulation and casting. That's a red flag for us. Okay, so that's how the Pirani score helps us. So it's not something that is used only for research purposes. It is something that's very practical for all of us to use. That right away we can red flag that something is going wrong with our manipulation and casting. We have to change something that is happening in the foot, or the foot really is something bad. Because even I would say sometimes I think I've done so many Ponseti plasters now, but there are some feet which just don't respond, and that's fine. Because you do have some very rigid club feet. We do have some very syndromic club feet where the Pirani score will not change because they're so stiff, and these children then need surgery. So if we find that the Pirani score is not moving, that tells us take a break, stop and pause. Either something going wrong with our manipulation and casting, which is the more likely thing, or it's possible that if we are really good experts and we know that we're doing the best method of casting and manipulation, that something is wrong with the foot. But something is wrong somewhere. And that's what the Pirani score highlights. All right. So this is how the Pirani score is useful to us on a practical basis, and all of us should get familiar with its use. After some time, you'll realize you don't need any paper to guide you. I'm standing in front of you and talking because I've used the Pirani score so many times And it's so easy. If you break it down this way, midfoot score, hindfoot score. Midfoot look, feel, move, hindfoot look, feel, move. Very easy to use. So that's the advantage of the Pirani method, that it is easy. It on a graph tells you prognostically that there's improvement. The disadvantage is slightly subjective because, sometimes may say that this Pirani is 1.5, someone may say it's 1. So there is always some discrepancy in different people when they assess the foot. So the problem with the Pirani score, sometimes it's a little bit subjective, but that's okay because it is easy to use. So therefore, we prefer the Pirani score. All right. So any questions about this? So this is about scoring. And remember, when I said about scoring, always remember, we are not just looking at the foot first, begin with the general assessment of the child. Facies, neck, back, hips, at the bare minimum. If you are so good and you want to examine the cleft palate, you also want to examine the heart and find this child has congenital heart disease, very good for you. But the bare minimum, this is the basics that you must always examine. Then go down to the foot and grade the severity of the foot based upon the Pirani score. All right? Good. Clear to all? Any doubts, any queries? You still have a chance to ask even later on during the practical session. But remember that this is the prelude to understanding how we are going through with the Ponseti method. Right? Good.